I want to tell you about a patient. 78 years old, sharp as a tack, walked 3 miles every morning, lived alone, fully independent, came in for a routine checkup, left with a referral, then another, then a procedure, then a complication. 6 months later, he couldn't walk to the mailbox. The original problem, it would never have touched him. The test did. I'm Kent John, cardiothoracic surgeon, 15 years in the O. This is the conversation your doctor probably hasn't had with you yet. The math changes, and nobody tells you. When you were 50, early detection made perfect sense. Find something small, treat it fast, add decades to your life. That logic worked. It still works for 50-year-olds. But somewhere along the way, medicine forgot to update the rulebook for people who are 70, 75, 80. Here's the uncomfortable truth. The same screening that buys a younger patient 20 extra years might only buy you 2. And those 2 years might be spent recovering from the treatment, not living. I'm not saying don't see a doctor. I'm saying ask better questions, because right now, millions of older adults are going through tests and interventions based on guidelines that were never designed for their age group, and the medical system is slow to catch up. Think about it this way. Cancer doesn't always behave the same in an older body. Some tumors grow so slowly that a 75-year-old will simply die of something else long before that tumor ever causes a single symptom. Finding it doesn't save them. It just gives them something to worry about and a doctor something to treat. Once something is found, the machinery starts moving. Your doctor feels obligated to act. You feel scared not to. And suddenly, a healthy older adult is on a table under anesthesia for a problem that was never going to hurt them. This is what we call the cascade effect, one of the most underappreciated dangers in modern medicine. It starts innocently, a routine scan, a borderline result. Let's just take a closer look. That closer look finds something else. That something else needs a biopsy. The biopsy causes a small bleed. The bleed needs monitoring. The monitoring reveals an irregular heartbeat. The heartbeat needs medication. The medication causes dizziness. The dizziness leads to a fall. I've watched this chain of events play out more times than I can count. A perfectly functional 72-year-old walks in for a checkup, and 4 months later, managing 3 new diagnoses, 2 new prescriptions, and a fear of leaving the house. But does every test lead there? No. The risk is real, it is documented, and it is almost never part of the conversation when a doctor hands you a referral slip. So, let's have that conversation now. 5 tests still being routinely ordered for people over 70, and why you need to think carefully before saying yes. Let's start with one of the most common procedures ordered for older adults. The colonoscopy, for people in their 50s and 60s, genuinely valuable, finds polyps early, saves lives. The data on that is solid, but after 75, the math starts shifting. Here's what the research actually shows. Colon cancer is one of the slowest moving cancers we know of. From polyp to dangerous, typically 10 to 15 years. So if you're 76 and a colonoscopy finds a small polyp today, the realistic probability of that polyp ever causing you serious harm in your lifetime is quite low. Now here's the other side of that equation. The procedure itself carries real risks for older patients. The preparation alone can cause serious dehydration. That intensive bile cleanse the night before can trigger electrolyte imbalances in a 70 or 80-year-old body. That's not a minor inconvenience. That's a genuine medical event. Then there's the sedation. Older adults metabolize anesthesia differently. Cognitive side effects are more common than most patients realize. Some research suggests temporary and occasionally lasting cognitive changes following sedation in patients over 70, and there's a real risk of bowel perforation during the procedure itself. In a younger patient, serious. In a frail 80-year-old, it can be life-threatening. So ask this question every single time. If we find something, what are we actually going to do about it? Because if the answer is probably nothing aggressive, why are we doing the procedure? The American Cancer Society updated his guidelines. Colonoscopy after 75 should be individualized, weighing overall health, life expectancy, personal preferences, not automatically scheduled. Does your doctor have that conversation with you, or do they just hand you the referral? Ask every time. This one is harder to talk about because cancer screening feels like the most responsible thing you can do, and I understand that completely. The fear of cancer is real. The instinct to find it early is deeply human. But here's what 15 years of medicine has taught me. Finding a cancer and helping a patient are not always the same thing. Let's talk about PSA testing first. The blood test used to screen for prostate cancer. In men over 70, it frequently detects slow-growing cases that would never have caused symptoms. These are sometimes called, bluntly, cancers you die with, not from. But once that number comes back elevated, the cascade begins repeat testing, then a biopsy. The biopsy carries risks: infection, bleeding, significant anxiety. If cancer is confirmed, the pressure to treat becomes enormous. Surgery, radiation, hormone therapy. Each of these carries serious side effects: incontinence, impotence, fatigue, bone loss. For a cancer that was quietly sitting there, going nowhere, the U.S. Preventive Services Task Force recommends against routine PSA screening for men aged 70 and older. Not because the issue isn't serious, but because the harms of detecting it at that age frequently outweigh the benefits. Now, mammography, same principle, different cancer. Breast cancer screening after 70 finds tumors, but a significant proportion are slow-growing, hormone-sensitive cases unlikely to ever spread aggressively. Yet, finding them on a mammog often triggers the full treatment protocol: surgery, radiation, sometimes chemotherapy. I've seen women in their late 70s go through extensive surgeries for tumors that statistically were never going to cause them harm. The surgery, the recovery, the reconstruction, all of it took a year of their life, a year of pain, limitation, and fear. For what? I want to be careful here. Some breast and prostate issues after 70 are genuinely dangerous. This is not a blanket statement against screening. It is an argument for an honest, individualized conversation. Before your next screening, ask if this test finds something. What is the most likely treatment path? And what are the realistic risks of that treatment for someone my age? Ask it every time. The answer might surprise you. Let me ask you something. Have you ever had a cardiac stress test? Maybe you walked on the treadmill while electrodes tracked your heart. Maybe you were given medication to simulate exercise, and maybe the results came back with something. A flag, an irregularity, a let's look closer. If you're over 70 and you have no symptoms, no chest pain, no shortness of breath, no dizziness during activity, that test may have opened a door you didn't need. The problem with stress testing in asymptomatic older adults, the test has a high false positive rate in this population. That means it frequently flags something that looks like a problem, but isn't actually causing harm. And once that flag goes up, the next step is almost always catheterization, a procedure where a thin tube is inserted into your arteries to get a closer look at the heart. It carries real risks: bleeding, arterial damage, kidney stress from contrast, dye, and a small but real risk of stroke during the procedure itself. These risks are higher in older patients. Multiple large studies found something that should give everyone pause. In patients with stable coronary artery disease and no symptoms, stenting and bypass surgery did not reduce the risk of heart attack or death compared to medication alone. Let me say that again because it matters. For stable asymptomatic patients, opening up the arteries surgically produced the same outcomes as simply taking the right medication. So what should you do instead? Focus on what actually works: blood pressure control, cholesterol management, not smoking, staying physically active. These interventions have decades of evidence behind them and zero risk of landing you in a catheterization lab. Hip fractures in adults over 80 are genuinely dangerous. Up to 30% die within a year from related complications. So of course, we want to prevent fractures. Of course, bone density matters. But the way we're going about it after 80, it's not always helping. DEXA scans, the standard test for measuring bone density, are widely used and largely straightforward. The scan itself is harmless. The problem isn't the scan. The problem is what happens when the numbers come back low. Because when a DEXA scan shows osteoporosis in an 81-year-old, the almost automatic response is to prescribe bisphosphonate medications. These drugs work by slowing bone breakdown in the right patient at the right time. Helpful, but in very elderly patients, the picture gets complicated. They can cause serious gastrointestinal side effects, including esophageal irritation. Long-term use carries a paradoxical risk, a rare condition called atypical femoral fracture, where the thigh bone actually breaks due to over-oppression of normal bone remodeling. A medication meant to prevent fractures can contribute to one. So, what actually prevents fractures in older adults? The evidence is remarkably consistent: muscle strength, balance training, home safety modifications, grab bars, non-slip mats, adequate lighting, reviewing medications that cause dizziness, vitamin D, adequate protein. These interventions prevent the fall, and preventing the fall prevents the fracture. A DEXA scan won't tell you to install a grab bar. It will give you a number, and that number will likely trigger a prescription. If your doctor orders a DEXA scan, the conversation should lead to fall prevention first, medication second. What are you doing to keep me strong? That is the right question. Let me paint you a picture. You're 74 years old. No symptoms, no dizziness, no weakness on one side. You feel completely normal, but your doctor orders a routine carotid artery ultrasound, a scan of the blood vessels in your neck that supply blood to your brain. The scan comes back showing significant narrowing, 70% blockage on one side. Now everyone is alarmed. Referral to a vascular surgeon, a recommendation to operate. Here's what nobody tells you clearly enough. For asymptomatic patients, people with no stroke symptoms whatsoever, the evidence for operating is genuinely weak. Multiple major trials have shown that the risk of stroke during the procedure can equal or exceed the annual stroke risk from simply leaving the blockage alone. Read that again. The surgery meant to prevent your stroke could cause the very stroke it's trying to prevent. And yet carotid screening continues to be ordered routinely, partly out of habit, partly because finding a narrowing feels responsible. But responsible medicine means weighing what the finding actually changes. The American Heart Association guidelines are clear. Routine carotid screening in patients without symptoms is not recommended, yet it happens every day in clinics across the country. If your doctor suggests this scan and you have no symptoms, ask directly, what will we do differently if this comes back abnormal? If the answer leads towards surgery, ask about the procedural stroke risk, then ask about the risk of simply optimizing your medications instead. You deserve those numbers. So we've talked about 5 tests to reconsider, and I can hear some of you thinking, okay, what do I actually do? Do I just stop going to the doctor? Absolutely not. Please don't do that. What I'm describing is a shift in focus. Not less medicine, different medicine designed for what you actually are in life. After 70, the most important medical goals change. The focus moves away from hunting every abnormality toward preserving what matters most. Your function, your independence, your quality of life, your cognitive sharpness. That is what real medicine after 70 looks like. Blood pressure management remains critically important at every age. Uncontrolled hypertension is a genuine threat. It damages the brain, the heart, the kidneys. Cholesterol management still matters, particularly with existing cardiovascular disease. Vision and hearing checks are genuinely undervalued in older adults. Poor vision causes falls. Untreated hearing loss is now linked in multiple studies to accelerated cognitive decline. These simple checks have enormous impact on daily function. Diabetes management remains essential. Vaccination, influenza, pneumococcal, shingles, these are evidence-based, low-risk, high-benefit interventions. Don't skip them. And perhaps most importantly, a thorough annual medication review. Polyarm pharmacy. Taking multiple medications simultaneously is one of the most dangerous risks for older adults. Ask your doctor to go through every single thing you take every year and justify each one. This is proactive medicine. This is medicine that actually serves you. Here's the hardest part of everything I've said today. None of it matters if you can't talk to your doctor about it. I know that conversation feels intimidating. You don't want to seem difficult. You don't want to come across as someone refusing care. I understand that completely, but you are not refusing care when you ask questions. You are participating in your care. There is a profound difference when a test is recommended. Ask, what are we looking for, and what will we do if we find it? This single question forces a conversation before you commit to anything. Ask, what is the risk of this procedure for someone my age and my overall health? Age-specific risk is rarely volunteered. You have to ask for it. Ask, what happens if we watch and wait instead? Active surveillance is a completely legitimate, evidence-supported option. It is not giving up. It is choosing wisely. Ask, is this guideline based on research that included people my age? Many were developed from studies of middle-aged adults and extended upward without specific evidence. And finally, what would you recommend for your own parent? I've asked this of colleagues. The answer is almost always different from the standard recommendation. I want to be fair to your doctors. The system they work in is not designed to support these conversations. A typical appointment is 15 minutes. Ordering a screening takes 30 seconds. Having a nuanced conversation about whether it makes sense for you specifically takes 15 minutes that often don't exist. That's a systemic failure, but you can work around it. Bring a written list of questions. Ask for a longer appointment if you need one. Bring a trusted person to help you advocate. And if your doctor dismisses your questions rather than engaging, that tells you something important about whether that doctor is the right fit for this stage of your life. You have spent decades trusting medicine. Medicine owes you honesty in return. You deserve a real conversation, not a rubber stamp in a referral slip. Here's what it all comes down to. I've been a cardiothoracic surgeon for 15 years. I've opened chest. I've held human hearts in my hands. I have enormous respect for what medicine can do. The procedures I perform every week genuinely save lives. And that is exactly why I'm telling you this, because I have also stood at the bedside of patients who didn't need to be there. Patients who came in healthy, active, independent, and left diminished. Not because their disease caught up with them, because the medical system did. There is a moment in every one of those cases that haunts me. It's the moment before the first test, when the patient was fine, when the cascade hadn't started yet, when there was still a choice. That moment is what today is about, giving you that choice back, because right now, you still have it. Here's the single most important thing I want you to take from this video. More medicine is not always better medicine. After 70, the goal should not be to find every possible abnormality in your body. The goal should be to keep you strong, clear-minded, mobile, and living on your own terms. Those are not the same goal, and confusing them is costing people their independence, their dignity, and sometimes their lives. You are not a collection of numbers on a scan. You are not a list of findings on a report. You are a person with a life, and every medical decision should be measured against that life. What does this test change? What does this procedure protect? What does it cost if it goes wrong? Ask those questions. Demand those answers, because nobody in that exam room is going to ask them for you. This is a conversation I wish someone had with every one of my patients before they came to me. I'm having it with you now. I hope it changes something. So, let's bring it all together. 5 tests worth of serious conversation before you say yes. Routine colonoscopy after 75. Weigh the procedure risks against the realistic benefit for your age and overall health. PSA testing and mammography. Ask what treatment actually looks like before you agree to screen. The cascade is real. Cardiac stress testing without symptoms. Understand that finding something may lead to surgery that evidence shows doesn't extend life beyond medication alone. DEXA scanning after 80. Make sure the conversation leads to fall prevention first, not just a prescription based on a number and carotid artery ultrasound without symptoms. The procedural risk may equal the risk of doing nothing. Ask for both numbers side by side. None of this means avoid your doctor. It means go prepared. Go with questions. Know that you have every right to understand what you're agreeing to and why. Here's what I want you to do today. Write down 3 questions from this video. Bring them to your next appointment. Read them out loud. See what happens. And tell me in the comments, has a doctor ever ordered a test that led somewhere unexpected? I read every single comment. Your experience matters. It might help someone else make a better decision. If this video helped you think differently, share it with someone you care about, because this conversation doesn't happen nearly enough, and the people who need it most may be sitting in a waiting room right now. And remember, everything I've shared today is general medical information based on current research and my clinical experience. Your situation is unique. Before making any changes to your care, please talk with your own physician who knows your full medical history. That conversation is always worth having. I'm Dr. Kent John. Stay strong, stay informed, and stay in charge of your own health.